think we'll get started here in just a minute.
Can you hear me, Doug?
Yes, I can.
Well, let me know when everybody's on board and we'll go ahead and get this started.
Okay, great. I had to approve your video and your mic. I just did the same thing for Jim.
Okay, yeah, because I was wondering why I couldn't get that going for me.
I think everyone's by default turned off.
Okay. So do we have a lot of people on? Are we ready to go?
Let me just check here. I don't see Dr. Turner.
I see Jeff Chabot. I see Sticky. We got 16 people on right now. Well, let's go ahead and get this started. We know Dr. Turner will get on board. For everyone that's listening, my name is Steve White. Thank you all for joining. I am the CEO of Accelerated Biologics, and we're very excited to introduce the Regenalase laser system, which is, in my opinion, after being involved with regenerative medicine since 1999, this is one of the greatest and critical technologies that we're going to really see as part of our everyday use in the future. Of course, more data needs to be developed, but the preliminary data we have has been fantastic. In addition to the laser, Accelerated Biologics is more than just a PRP company. We're first to market with a lot of new technologies. We can talk about that down the road. Doug Saylor has been pivotal in helping to do a deep dive in this technology. And I've asked him to go ahead and kind of play the role of MC for this conference. And I see Dr. Turner's on board. Hey, Dr. Turner, good to see you.
Hi, guys. Sorry, I'm on my wife's work computer, so it says Melissa. Sorry.
No worries.
No worries. No worries. So what I would like to do is I'd like to go ahead and have Doug, kind of really introduce the laser system to everybody out there real briefly. And then we're going to have Dr. Turner jump on and share his experiences and more importantly, how his patients are doing. And then we'll go ahead and field some Q&A. And we want this to be very relaxed, very open, and very free. I'm going to turn my microphone off and my camera off so that you guys can focus on what Doug and Dr. Turner have to say. And from that point forward, Doug and Dr. Turner, take it away.
Okay. Hey, thank you, Steve. Appreciate everyone that joined today. Steve mentioned, I've been, leading the charge here around the country, flying all over, doing cases with a lot of doctors. It was my pleasure to be doing a lot of cases with Dr. Turner when he first got going. I'm going to give a quick overview just on what the machine is and how that works. And then Dr. Turner is going to go ahead and share his experiences, I think some of his protocols and some of the data as well. So let me just share my screen here. Just a second. Not sure why this isn't working. Hey, Felix, do you need to approve me to share my screen? Let me check something here. Just a second. Apologize. Well, I'm not seeing, this is not working here for some reason.
Hey, Dr. Turner, are you able to share your screen?
Yeah, I have some sort of issue here. It's not allowing me to share my screen.
Can you guys see that?
We can see that. Yep.
Okay. Okay. That's something for my wife's work, so I'll stop that. But let me see. I could probably email the presentation over real quick. Give me a second, Doug. Sorry.
Well, no, you hold on to yours. I was just going to do a quick run through on the slides I have. But of course, I'm not, for some reason, it's not allowing me to do this. Security privacy screen recording. Just one second. I think I figured it out. I did this last time. I don't know why it's making me reapprove all this.
Looks like you guys are both in the same condo.
Well, I'm having some technical issues. Okay, so I'm just going to give you a quick rundown on it, and then Dr. Turner can share his information. So the system is fairly small. It'll fit on a Mayo stand. It is 2 lasers in 1 unit. So there is a topical laser. It's a 980 wavelength, and there's a 1550 wavelength laser that is an interstitial laser. So that's the really key thing here is that interstitial laser is the only one in the world. You can treat various soft tissue, whether that's cartilage and articular cartilage in a knee, tendons, ligaments, or even in the intradiscally, by using an 18 gauge needle and putting the fiber through the 18 gauge needle and then accessing that soft tissue directly. The topical laser is as I mentioned, is a 980 wavelength. That is a class 4 laser. You can train, you say, an MA to utilize it so they can do treatments for you while you're doing seeing other patients doing other procedures. The interstitial laser is a laser that you would need to do as a physician, usually under ultrasound or under fluoro. And then you'll be able to access it that way. Being I don't have my slides, I'm just going to let Dr. Turner go ahead and share his experience and some of the data from his slides as well.
Dr. Turner, you're on mute.
All right, guys. Let me see if I can make this work with the presentation of the night. Let's I see all this share content stuff. Can't just view the screen. There we go. Oh, it's asking me to grant access. Okay. Open system settings. Doesn't want to do that. Google Chrome would like to record this computer screen. I don't know. Won't let me do that. Weird. What's that? Oh, I got it.
Yeah, I had the same issue. It was trying to give me all these permission things. I don't know what's going on with
Okay.
Microsoft. Maybe they made an update and we have to approve everything.
Let me see if I can. Okay. Quit and re.
I think we're having some technical difficulties here, so I apologize. I think Dr. Turner had to log back in after he changed his settings, so hopefully we'll have that situated in just a minute.
All right, let's see. Doing that. Now I'm gonna try and share screen window or tab. Select a tab to share. See, I don't know if they can hear me. Can you guys see me and hear me okay?
Yeah, I can hear you. I can
Okay.
see you too.
All right. You want you
Okay, we got
screen-
it. I can see it.
all right, guys. Thanks.
I see the presentation. I see the presentation.
Perfect. All right. Well, look, so thank you guys for taking the time to be here. You know, I'm PM and R doc by training. Kind of worked in sports and spine, started out at Andrews for 4 years, and that's where we started doing PRP and BMAC in the last probably 4 or 5 years. Started doing more MFAT, got really interested in applications where we could potentially help patients recover faster. So, you know, for me, most of the time, if I have a consult with patients and they're an appropriate biologic candidate, what we usually say is, you know, listen, you know, we do a follow up at 2 weeks. You're probably going to say the first, 2, 3 days post procedure that you hurt a lot. And at 2 weeks, you're not going to be much better. At 6 weeks, you're going to start telling me that you're doing better, but you're not going to be better to the point that you're ready for return to sport or play, depending on, how advanced what you're trying to do is. And usually 12 weeks and beyond is when we see our best outcomes. And I'm sure there's a lot of smart people on this webinar that have had a lot of experience doing regenerative medicine. So I'll let them share, their experience at the end. But, one of the things we have found with the laser, and one of the reasons I got really interested in it is the patients that we are treating with the laser, we've only been doing it since November, so we don't really have long-term data at this point. But kind of what my experience has been, almost universally to this point with everyone is that they get better much faster. And because some of the procedures we're doing, are fairly advanced that people are paying a lot of money for, patients are obviously motivated to get better faster, and they're wanting to do that in a way that's safe and oftentimes it's innovative. And so, seemingly the early adoption of the Regenalase laser has allowed us to do that. So you'll see a couple things on here. One is to summarize some of the studies, and Doug didn't get to reference all of those, even though he knows the data backwards and forwards. I've had him and Steve present to me before, and they're great with it. But there's a huge number of disc spine patients that have been treated in a clinical trial. There's a good number of knee patients as well. So anytime someone asks me to adopt a new technology, I'm always trying to figure out how much actual human data is there. And I give patients a framework where I recommend ways that they ask their doctor about doing regenerative medicine before they commit to it. And because of the amount of data in humans, I think this helps to give people some confidence. So we have patented something that's a provisional patent now. We're actively looking to raise some federal funding and some other grant funding for it around a gene profile that captures about 25 different loci that helps us to predict and make clinical decisions about what kind of graft we should use with patients, and then what kind of rehab and prehab to do with them to optimize their outcome. I included that here because it's a unique thing about our practice, but it's also not the purpose of this presentation, so I don't want to spend too much time on that, but happy to take questions about it if people are curious. So obviously, one of the things about the laser that's very important is it is cleared by the FDA for orthopedic use, which is really kind of in the, the space that we're in, obviously. And meniscus cartilage being one of them. We have done, a dedicated meniscus case by itself, even though most of our cases have either been to treat knee cartilage, and now we've been doing facet disease in the spine as well. In some cases with people pre-op, in some cases with people who've had prior fusions and have adjacent segment disease. We talked a little bit about the patent. We talked, this presentation, obviously I'm sharing things that have been, accumulated in my practice. It's not being endorsed by IPG Medical or Accelerated Biologics. This is just my own use. And, for us, based on the FDA's definition of human cell and tissue products, we feel that we autologously use PRP, BMAC, or MFAT, and that's consistent with the FDA's guidance. We don't use any allografts or, other products that are kind of off the shelf. So brief agenda, we talked a little bit about the science. I want to hit on cartilage biology because I think that's important for why I would recommend sort of some new ways to approach using this laser. And then there's some data from the knee, there's some data from the spine, and where I want to go with it is to start talking about hips. So Doug already described kind of the mechanisms, of the laser delivered through an 18 gauge cannula. For us, we're usually using smaller needles than that, but if we're trying to deliver larger payloads, whether it's with BMAC or something like MFAT, we're using a larger gauge needle anyways to deliver them. So it was a convenient, treatment protocol for us. Especially while the cells are processing or spinning down. We're not using nanoscope at this time. We are using ultrasound and fluoroscopy in combination in most of the cases that I do. There was a lot of debate, I think, early on, and people who looked at adopting this technology saying, well, if you don't use arthroscopy, you really can't visualize cartilage very well. Obviously, we use fluoroscopy in the spine quite a bit, but I get the privilege to kind of learn from some of the best people in the industry at Gulf Coast Biologics once a year when I go teach kind of very basic things. And then, I sit down and listen to some of the masters like John Jacobson and some other folks from, Mayo kind of come down and talk about advanced applications from ultrasound. So if I have questions, I ask them questions. And I felt, and I think a lot of people feel, that you can scrutinize the cartilage pretty well with ultrasound, depending on, kind of the patient positioning and what it is that you're looking to treat. So we do, operate in what we would consider an office-based surgery suite. So we've only been open at this location in Atlanta since July, so we're not an ASC yet, but we are probably looking at some accreditation for that. And then the three kind of big mechanisms of the things I always talk about with patients are, how does this laser work and why do we use it? Because we already had pretty good outcomes over the last 10 years. So we talk about kind of the microscopic thermocoagulation, which is part one. And I think some prior presenters on this, these webinars have pointed out that there was an old kind of ablative laser that was used in orthopedics that may have been, overpowered or used the different wavelengths that kind of led to bad outcomes. So, depending on who you talk to, sometimes you need to make that, differentiate or talk about it. I talk about the nanopores quite a bit and about the fact that the nanopores are so small you can't see them with a regular microscope. And the IPG team was very generous to kind of share with me even some of the histology from the slides, which, basic science obviously doesn't get us all the way to a touchdown, but it's nice to understand the mechanisms behind what we're doing, kind of in an avascular matrix to be able to open up those small areas. And then, the other slide that comes from the Regenalase kind of deck or brochure has to do with that mechanotransduction signaling where, even in vitro in 10 days, you can really see an appreciative increase in the chondrocytes, which obviously is interesting and something that, frankly, with the paracrine mechanisms of the other things we do, kind of may or may not be happening because we're not doing biopsies on people after we're treating them. So kind of just a brief review about the basic science of cartilage. So I had looked at, I'm not a radiologist, but I'd looked at kind of advanced applications of MR spectroscopy and the way we quantify discs that are symptomatic. And there's some pretty good European spine journal studies about how to layer that on top of a traditional spine MRI. It's hard to find places with the technology to even do that. And it's harder to find places that will agree to a contract to do that. But the reason that that was interesting is when I started looking at it, the types of collagen that are inside an intervertebral disc are very different than the types of collagen that are in a knee. And so for me, the fact that there were, studies that primarily came out of spine, originally from Russia with Dr. Baskov, and then the studies that came out, later on the knee was pretty remarkable because the fundamental composition of those types of cartilage is very different. Obviously, we do see fibrocartilage in the disc. We see hyaline cartilage in the knee. There are some notable differences in the ways those develop from embryology, and then there's notable differences about the types of collagen that you see in there, type 1 versus type 2, and in the orientation of them and how much proteoglycan is in them. So I was kind of quickly impressed by the fact that there were applications in both of those sites, and that made me think a lot about areas that were available in other parts of the body. And I think the part that has been made very clear is that currently the Regenalase surgical laser is available in kind of a 0-degree orientation, much like what the nanoscope uses compared to traditional arthroscopy that uses a 30-degree scope. And so, to some extent that limits what we're able to do, right, when it comes to application of different joints. But I think, IPG and some other people have kind of mentioned that they initially had a 90-degree bend. I think that would extend a lot of the applications that we're able to offer currently in the body. But what's important to me is the fact that, hip obviously has an acetabular labrum that is fibrocartilage, and it's almost always, not universally, but almost always symptomatic or torn or degenerated kind of in the same place. And it's pretty easy, typically in the hands of an operator who looks at these a lot to see them under ultrasound and to see these clefts. And, frankly, most of the patients that we're offering these procedures on, do have an MRI first for planning or staging, but nonetheless, the mechanism or the way that we would visualize the treatment site with ultrasound is quite good. So we see a ton of patients with hip labral pathology who frankly have missed the window or are not great candidates for, hip arthroscopy. And oftentimes that's either because they, have some coexisting kind of arthritis or based on the amount of, impingement they have or the amount of, the alpha angle, the way we look at that may not be ideal candidates or age to go get a hip arthroscopy. So we do a lot of PRP for it. We've been doing it for years. We tended to use PRP for kind of easier cases, and we tended to use BMAC for bigger cases. My experience now, frankly, is we use mixed grafts in most of the cases that we do because we're looking to combine different aspects of the biological milieu to get better outcomes. And our patients, at least who see us here, appreciate that. But so, similar to kind of these other, aspects, the collagen in the hip is type 1 and 2. It is proteoglycan poor, which is a little bit different maybe from the knee or the disc. But nonetheless, we see, kind of like the spine when people hurt their labrums, especially because it's designed in such a way that it has a kind of a hydrostatic seal around it. Once that seal is broken, then we start to see more progression of pathology or arthritis or pain and functional limitation over time. So we're seeing a lot of these patients. They don't have a lot of other good options, which is why I think Regenalase with an appropriate biologic is the right thing, to consider based upon the case that you see. So, couple things here about differences in tissues, and obviously, I think people can, download these slides and read these in more detail because there's I'm over 40 and it's hard for me to see these now, but um, I think anytime we're looking at avascular cartilage, we're trying to think about what is the potential for repair. Do we need a stronger graft like BMAC because we know that there's a little bit more potential for anti-inflammatory, mechanism with IRAP there, or should we just use PRP or should we combine those together? And if so, what's the basic science behind them with PDGF and TGF beta from the platelet aggregation and release? And then in our case, something that's unique is the way we use what we call the Cartinova bioprofile. And so that profile is we do whole genome sequencing in my practice, but we're grabbing basically about 25 different SNPs or single nucleotide polymorphisms that allow us to kind of split people into about 5 clinical phenotypes. And then we use those phenotypes in combination with some lab work that was based on a paper that was published by HSS out of New York to kind of try and metabolically optimize somebody for therapy depending on, where they're at. So this is the knee data. This is not our data. The real world outcomes on the stage 3 and 4 OA cases are presented in the clinical trials that's available from the Regenalase, deck and from Accelerated Biologics. We talked a little bit about what kind of, collagen is in there. And obviously we talk a lot about the difference between what we would consider to be a paracrine mechanism versus actual differentiation. I know there's a debate there, and it seems that, most people at that debate have leaned toward the paracrine mechanism as being the more, significant aspect of how basically that works at this point. But, even though it was only 52 patients in the knee study, I was, of course, very impressed that a lot of them were stage 3 or 4 because we, tend to say, that patients with earlier stage disease will do better. And oftentimes the patients in our office are, have already had surgery or they are moderate to advanced in OA. And so, they're looking for ways to avoid or delay knee replacement if possible. And I was impressed by some of the patients in the knee study that basically showed that people were, stage 3 and 4 and they were getting better. But so the idea is that, of course, as the laser goes in, you can, kind of prep the soil, so to speak, to receive the graft. And, for us, we have good techs, but it takes about 35 minutes or so to process BMAC after it's drawn. We mapped the femoral condyles basically into zones. And so we use kind of what people call the carpet, bomb technique, where we will do a minimum of 9 and usually 12, where we say, okay, well, we're going to do kind of 3 superior, middle and inferior, and then 3 that are kind of medial, midline, and lateral at a minimum, sort of just depending on what we identify from the MRI. And the interesting thing is we've done that with people awake, just under local, and they don't feel anything. So I was a little bit nervous the first time, we turned the laser on, and, we give people, of course, local medicine, but I don't want to give them too potent of a block or too much volume of anesthetic inside the joint because I don't want it to dilute the payload of my regenerative biologic. But in our case, we just had people that we treated with the laser initially, and they would just talk to us during the procedure and they were fine. So that was interesting to me because, we'd use some other kind of percutaneous high powered orthopedic lasers, just through the skin, not intra-articular, and they were of course different powers and wavelengths, but tissue heating is something that we worry about. So I wasn't sure how that was going to go, but it appears that the power and the wavelength of the surgical laser is just kind of very well tolerated by patients, to the point that I've had people actually work out the same night. Now, I don't tell them to do that, but we have some people that are kind of very hard chargers in our practice, and we're grateful to see them. But anyway, I thought that was kind of remarkable. But and I enjoyed Rowan Paul's presentation about how he used the laser actually during an intraosseous or subchondral procedure. We've not done that yet to this date, although we do have a case like that that's posted in May, so we will be using it for that application as well. For somebody who has underlying subchondral edema and medial femoral condyle and the tibial plateau, that we'll treat with an intraosseous injection. But nevertheless, so 52 patients in the knee study. And these cases are not my cases, but these are from the, this is basically they're categorized well, kind of based on the outcomes. And the key slide or picture that I'm not really showing here is the actual improvement of the cartilage layer 6 months out on a human MRI. And most of the time when I see things like that, I get pitched a lot of ideas because I help commercialize novel therapeutics and medical devices with different venture capital companies. But my first instinct is always to disprove those things and kind of share with everybody why they're BS, or why it isn't even the same picture of the same person. And so what became very clear to me is that this work was done well, and it was. And in my opinion, we really just don't have a lot of other mechanisms in the practice of medicine, even with really great, sophisticated intraosseous, well-dosed biologics that show that people actually get new cartilage signal on MRI. Now, we see people get clinically better, but we don't always see them get, better with macrostructural changes like that, even if we're changing the kind of the intra-articular biology of what we do. So, by far, there's been a lot more study in the spine than there has been in knees. In my case, we've used the laser to integrate into the facet-based approach, and we do kind of what people here are familiar with, probably with the the percutaneous spinal unit approach, as some of the Regenexx guys started to coin that term. But where typically if we do a procedure, we'll plus or minus disc depending on the indications and the safety, but then we'll do the facet joints, we'll do the epidural space, we'll do the multifidi, we'll do the ligaments, and then other joints, SI joints or peripheral things if needed. So that tends to be our approach. We've used the laser now for that, both in pre-op and or cases that have not had a prior surgery, and then in the cases that have had cervical fusions before for adjacent segment disease. Those cases are pretty fresh, so wish I had data to say, well, they did great and did better than all the other cases we did. But we're always cautious to kind of tell people, listen, if you've had prior surgery, most of the time our outcomes are not as good as they are kind of in a native joint, even in moderate to severe disease. So it'll be sort of exciting to see what comes out of that. I do kind of tell people, so I have a framework where I tell patients how to ask questions about who to see as a regenerative provider. And so one of the questions I tell them to ask, was a hard question sometimes, depending on the case, is, well, like, how much human data is there behind this specific application? And one of the things that I think you can be very confident saying for people that you're going to treat in the spine is that this is actually the longest running fractional laser cartilage study in the world. And I got to, meet or speak with Dr. Baskoff on one of these prior webinars, and he was obviously very knowledgeable and answered some hard questions, but that number has been almost 500 patients in a clinical trial, and he's treated over 4,000 with very few incidents of complication. And so I share that obviously with patients. Excuse me, when we talk to them about that, I think, one of the things maybe we're looking at that may be considered a little bit innovative in the space is we, have some experience kind of doing what people will call basovertebral nerve ablation, where you drill basically down through the pedicle and go into the pedicle into the vertebral body and do vertebral treatment that way. We're kind of evaluating a way to do that with some of our biologics. Most of the time, the most advanced biologic we use is either PRP or BMAC or some combination, and then we're doing that intradiscal as well as with the rest of the spinal unit. Personally, I don't do cervical intradiscals. I just, when I was younger, maybe in my career, I wanted to do all the cool procedures, and then I haven't had any bad outcomes, but I just felt like that was a risk that I personally kind of didn't really want to take. But I'd be interested to see if some other people around the country do feel confident to do cervical intradiscal procedures with the laser. It'll be, interesting to see how that goes. So as it pertains to the hip and some of the degenerative labral tears, that we're seeing, or even tears where we see tears that are less than 4 millimeters, those tend to do quite well with PRP in my experience. The question is sort of, we have this, type 1 collagen on the outside, and we have type 2 on the inner zone, which is pretty avascular and doesn't have a ready self-repair mechanism. So 2 of these cases we have posted now. We have not done them yet. One, it's interesting. They're very different kind of athletes. So one is a champion weightlifter who actually we had treated in the past with intradiscal BMAC, and she did excellent and went from almost filing for disability to come back and compete in the Arnold again. So that's exciting. But, nonetheless, the amount of kind of sheer force she puts across her hip and spine is very different because she's competing in Olympic snatch and some other things that, are unique, I would think, in terms of the load that she puts on herself. The other athlete we're seeing is actually competing in the World Championship Ironman this year. And so while he's not lifting heavy weights overhead all the time, he is sitting in a flex position on a bike for many, many hours. So it'll be, we're looking at how those go. Part of the reason those cases are not scheduled immediately is it takes us about a month to get the whole genome sequencing back. And then, they of course have races and other things going on that they're trying to navigate around. So we're figuring those things out with them, but there is probably a correction that needs to be made on this side. So I know it says fluoroscopic guided hip joint access here under the hip. We are actually using ultrasound to visualize the labrum pretty well, even though we do use fluoro for other hip applications. So that should probably be changed. But, nonetheless, I think that this is a good application of the laser that should be considered. We are usually not treating advanced hip arthritis like, tonus grade 3 or up, especially because the rehab after a hip replacement for patients with advanced arthritis is really kind of minor, I think, compared to the other joints. So that would probably be the thing I refer most for surgery in somebody who's got advanced arthritis. But we'll probably, maybe evaluate that in the future, because our outcomes with biologics for hip arthritis have not seemingly been as good as they've been for labral pathology. And then I'm going to quit talking pretty soon because I've been talking too long. But so just a brief bit on the Cardanova bioprofile. So, we do a whole genome sequence to get patients' DNA, and then we use that clinical decision framework to help us make decisions about precision orthobiologics in patients. We found that this is a pretty novel approach, and we're trying to compete for some grant money around this. We have some, kind of expectations that we'll be successful there with the right team. But nonetheless, we kind of separate people into 5, profiles. So we look at somebody as either a kind of an optimal PRP responder, a conditional PRP responder who will do well if you kind of modify the PRP in some way, or basically, increase the dose and or, activate it, or now what we consider is using the Regenalase laser with it. People who are preferentially BMAC responders, people who tend to have very high inflammatory states, and then those who are very slow healers. So that has kind of implications on how much shockwave or laser we would do both before and after the procedure. And I'm a big fan also of using BFR, blood flow restriction. I had a physical therapy gym that I was the kind of medical director for. So I've had the chance to learn from a lot of great therapists and try to think about how we approach both the pre and post rehab. And one of the things we've seen, since my time, even that I started my career, is we had a tendency to start saying, well, the surgical rehab's like this, so rehab after biologics is going to be very similar. And I think what we learned pretty quickly is that, rehab post biologics is very different than rehab from surgery. and has to be modified appropriately, especially in somebody who's, hyperlax or, kind of has other concerns that would make them a better biologic candidate and a poorer surgery candidate. So anyways, I wrote kind of some of the genes out here. I mean, most of the people on this webinar are probably smarter than I am. So you guys either know this or you can look this up if you're interested in it. But this is kind of a sample of some of the some of the genes that we pull, and how we sort of put this framework together to be able to, sort patients into these 5 buckets, so to speak. And then to think about things we would do in advance before the procedure to optimize somebody's outcome, to receive the quote biologic. And so we think about these people with the pro-inflammatory phenotypes. I thought I corrected that, but it got misspelled. Sorry. Being a good candidate for BMAC, and then people with laxity using PRP to help with scaffold support, people with, maybe poor response or where they have a lot of adiposity that's replaced their bone marrow, we may consider using MFAT instead, depending on what we're trying to treat. And then, thinking about how we modify rehab for somebody depending on their metabolic risk or what other factors to consider there. So this is kind of the patient journey for us. We do our consult, we do the whole genome sequence. It takes about a month for us to get that data back, start on a prehab protocol, modify it as appropriate based on metabolic factors, then do our procedure with the Regenalase laser combined with the orthobiologics graft, do a rehab protocol after that. Now, we've not, frankly, gotten 6-month MRI data yet because we started doing these cases in November. But we've had some pretty cool success stories in the early going, which are fun to talk about. And then, I've been speaking with Luke Malonga over at Data Biologics to kind of figure out how to capture this data. And I think some of the things that the therapists have talked about with me is, when we first started looking at this, we would say, okay, well, how many watts did we put through the laser, and like how many seconds was the laser turned on? And I think similar to the way when I first thought about PRP, and I would say, okay, well, how many X is it over baseline? And now we almost never talk about how many X it is over the baseline, and we talk about, how many billions of platelets did you get in your dose? I think that's the way we're going to start talking about the laser, and we're going to start saying, well, how many joules did the patient get? Because that's really what that's the intervention that we need to measure, and then that's what we need to capture with our outcomes data over time. So anyway, so this is the integrated pathway, and then we talk about obviously these different applications for why we do it, and I appreciate you guys taking your time to be here tonight. It's late and you could all be with your family. So thanks, and happy to shut up or answer questions if anybody has any.
Well, thank you,
Well,
Dr. Turner. Yes, go ahead, Steve.
Yeah, Dr. Turner, that was awesome. And I appreciate you saying all those nice comments. And you're so right. We talked about X times concentrations of platelets, and now we're talking about, how many billions of platelets are delivered. Same thing with the laser. This is new technology, but it's being proven. We keep hearing of the docs who've been using it, the docs that are, jumping into the game instead of staying on the sidelines. We keep hearing repeated results and some great success stories. So I'll be interested to hear the conversations and the questions that are going to come. So Doug, I'll let you take that over, but thank you, Dr. Turner. That was an excellent presentation.
Thanks.
Yeah, and then just a reminder, anyone that has questions for Dr. Turner, just go ahead and type them into the chat, and he can go ahead and answer those for you as well. I am going to try to share real fast. I may have fixed that issue I had, and it is not allowing me to it. Well, it's not going to allow me to do that. It's unfortunate. Okay, is there anyone that has any questions right now? We had a question about it being shared. Yeah, we will be able to share the recording with everyone on this so they can look deeper into the slides. Dr. Turner, can you talk a little bit about, are you using the extracorporeal laser separately or just in conjunction with the interstitial laser?
We've been using it. I think, one of the things we do is depending on if we have to do tenotomies or not and stuff, we prescribe typically narcotic pain medicine for people for the first 72 hours. And I do think, because we don't want to give them anti-inflammatories. And so It does seem that the extracorporeal laser is allowing us to use, or allowing the patients rather, to kind of have less need for narcotic medicine or inflammatory response post-procedure. Now, it's an interesting thing because people say, well, don't we want inflammation like as much as we can have? And in my opinion, the answer to that is no. But I think we've seen pretty clearly that, the use of kind of non-steroid anti-inflammatories in the COX-1 pathway, obviously that negatively affects biologics, but that's one pathway. And so, my opinion is that if we can kind of reduce some of the early post-op pain period, then the goal is that we can move people faster. And my general, it depends on the patient, but I would say generally, I favor earlier mobilization a little bit more robustly than I do kind of lockdown periods. And so I think that's helpful. Now, the hard thing for us has been right now we don't have a PT in-house. So we have, one guy in particular who will come, a day and a half a week and he'll do some rehab there. But a big referral source for us is concierge physical therapists in the community. And they tend to be very knowledgeable, which I've found, I've been surprised by because a lot of PTs are not experienced maybe in doing regenerative medicine rehab, but and they already have shockwave technology and they already have laser technology. It does seem like there is a laser that's been used in the PT world that's kind of been, maybe Light Force. I think they've kind of committed to education of a lot of physical therapists. So I think the result is they have those lasers frequently. Now the settings or whatever may be a little bit different than the Regenalase laser, but obviously, for us, if somebody's in the practice, they're getting a procedure, we can use it. If and when they come to follow up, it's an easy thing to use. I trained a technician basically in my office to use it, mostly for knees and spine, is how we've been applying it thus far. And then we've done some other percutaneous laser stuff for plantar fascia and other things that are common. But so we probably have not had as much experience in the post-procedure period just because many times my patients go back to the PTs that they came from.
Okay, no, that's a great answer. I have a question here. Have you done many of the hip labral cases, and what are your early impressions of them?
Well, in my career, have I done them or
No,
with the
with
laser?
Regenalase.
No, I have two on the schedule, neither of which that we've done yet.
Okay.
Yeah.
What pathologies have you done with Regenalase that you think are say the strongest results out the gate?
Knee arthritis, meniscus tears, facets in the spine adjacent segment disease, and then we've got two intradiscal cases on the books that we haven't done yet. But obviously that's a big one. I'm always like a little, cautious about that. I've never had a discitis to this point in my career, 10 years in. We do use ANSEF and some other things to try and decrease that risk. So I kind of, I'm one of those people who makes a big deal out of the 1% risk with patients. And so we will generally try to treat the spine without an intradiscal approach first if we can.
Mhm.
But I know from experience there are just some people they're just not going to get better unless you treat their disc. So does the kind of end plate edema or motic changes that we find play into that? It's my opinion that they do. But yeah, I mean, but we do have a couple of those cases on the books, and so kind of excited to talk about that after they're done. One of them is actually a pretty, not a very old guy, 29-year-old tennis player.
Oh,
So it'd be interesting to see, how those go. And then there was something I didn't speak very much about, but we do use a different kind of a force plate technology called an Oxfit system. And so our idea is to kind of get some mechanical, actually biomechanical load data from that, both before and after. So it's great to hear patients say they don't hurt and play sports again. It's great to get MRIs and have them look nice. But I think for me, understanding that somebody's physically able to perform in a way that's different and can tolerate more load is something I'm really interested in. And so that's what I really want to see in the long term.
Well, I mean, and to speak to that, they're just, the outcomes themselves of what patients are seeing. I mean, we did those cases back in November, and you reported, at least on a couple patients that, got back to pretty robust activity pretty quickly.
Yeah, we
There's,
had a marathoner who she'd run over 120 half marathons and I can't remember how many fulls, and had pain since June, had an orthopedist tell her she needed to quit running. She was like, I can't stop running. This is my identity. It's my life, which is understandable for somebody like that. And that was actually before we were combining the approach. So for her, we did Regenalase just by itself. And she had run 10 miles without pain in 3 weeks and did a full half marathon, or did a half marathon, I should say, 4 weeks out with zero pain.
wow.
So that was, it's an N of one, but it was interesting to me because runners, who run that much, they put a lot of, load across or torque across their joint, which really matters. And, they're never going to quit running, unless whatever, if they just can't, they have to get a knee replacement. But so that was an interesting case. And, it was also interesting how fast she got better. So I would have ordinarily said, listen, 6 weeks out, you're really going to start doing better and you should start building your volume back up, with the idea that your race, best race ahead of you is probably 12 weeks out. But she did well so fast. So, I think now she was probably metabolically, healthier than some of the other people we treat. And that matters, obviously. But anyways, it's exciting to see that happen because we like to get patients better and we like to do it in a way that it meets their kind of objectives and goals, I would say.
Yeah, that's great. That's great. Any others from those early cases that we did that you got some good feedback on?
Yeah, I mean, the feedback has been good. I think, for me, we kind of did a couple layups I would consider in the beginning, and that was nice. I'm really interested to see the really hard case. We did a case Friday where we did, adjacent segments above and below a prior cervical fusion with MFAT and PRP combined into a knee plus a meniscal tear. Like that to me is kind of a big case. And so I'm really excited to see like how those patients do, because we've got a great track record with biologics now. We've had enough data over 10 years to be pretty confident what we recommend. But I think it's the cases where I'm going, this is a hard case and I'm not sure if the outcome's going to be as good. Like those are the things that I really want to see Regenalase help with, in my opinion. But
That's great. Well, thank you
yeah.
so much for sharing all that information. We're really looking forward to hearing your results as time progresses. I think we're don't have any more questions right now, so I think we'll wrap it up and let everyone get home and see their families. But thank you very much. Thank you everyone for coming. We appreciate your time, and we look forward to seeing you next time.
Thanks, Doug. Thanks, Steve.
Thanks everybody.
Sharon.
Sorry for the difficulties on the Microsoft Teams, but we'll take it up with the folks at Microsoft.
Call Bill.
There you go. Thanks, guys.
Thanks. Take care, everyone.
Bye-bye.
Don't piss him off. I'm trying to get a grant from the Gates Foundation.
I'll do my best.
All right.
Right.